Welcome to the Psychology of Black Womanhood podcast, the space where research meets the real world. I'm Dionne Stevens, and today we're talking about Black women's experiences with infertility. The prevalence of infertility in Black women is a topic that's really gained increasing attention in recent years, and a lot of this is tied to the fact that Black women are more likely to experience infertility when compared to women of other racial and ethnic backgrounds. Contributors like socioeconomic status, access to healthcare, and even cultural beliefs can all play a role. To explore this issue, including identifying factors that can support Black women experiencing infertility, today we're talking with nurse researcher and fertility coach, Dr. Morine Cebert. Dr. Cebert is a nurse researcher of reproductive endocrinology disparities and inequities with a particular focus on Black women's experiences accessing care to infertility treatment services. She has been recognized by domestic and international reproductive societies for her foundational research that centers the voices of Black women and their families. So before we get started, I think it's important that we're on the same page in understanding exactly what we mean when we talk about infertility and Black women.
First, thank you so much for inviting me. This is so exciting to share. It's not only my research, but a passion of mine. And so really helping to highlight and explore the reasons of infertility in the Black community and why it's so hard for people to believe that Black women experience this. And so, infertility is, let me first define it. So we have a couple definitions of it, and the American Society of Reproductive Medicine recently changed the definition, but what's widely accepted in the United States and Europe in terms of the medical diagnosis, it's the inability to conceive or bring a child to full term and deliver a live baby after 12 months of consistent sexual intercourse. And that's for somebody that's younger than 35 years old. Older than 35, 36 years old, we're going to give that person about 6 months of trying and not being able to conceive or bring a child to full term. And so in the United States, it's about 1 in 5 couples that experience this. It's about close to 18 to 20%. And the thing about infertility, it's actually kind of hard to track it in like an epidemiological sense because it requires somebody to actually go to their medical providers and say, hey, this is my problem. And so when I started looking at it for Black women, specifically in the United States, I do have an interest to look at the broader diaspora. There's a lot of fertility work done in sub-Saharan Africa as well, too, and just thinking about that. But my work mainly focuses right now on women in the United States. We're not talking about this. So the numbers are not actually making sense in terms of how much it's actually affecting people. But it affects us when we think about Black women and our experiences with fibroids and endometriosis. All of those play a role in terms of our fertility. And so when I ended up doing my research, I realized the numbers are actually really bad because, I talked about that 1 year and the 6 months. Women in my study were waiting up to 10 years to actually seek treatment. And so it's one of those things that we still actually need to track in figuring out how bad it really is.
Why is it that Black women are stalling or that we're taking so long or we don't even want to talk about infertility?
Yeah, so that takes me back to my one of my first papers from my PhD program. It was a concept analysis on Black female fertility. And so it really brought me into the literature of womanist information, reproductive justice, and looking at how we view Black women's bodies. And I quoted a lot of powerhouses in that paper, but definitely Dorothy Roberts, who's at UPenn right now, was foundational, really helping me understand this is not a right now problem. This is a historical problem. So when we think back into slavery, it was actually very good for Black women to have multiple babies. That made the slave industry flourish, right? We had a lot more workers, who were there and available. And so then now we get into this post-slavery Reconstruction era now having children is a problem. Now we're having too many babies. And in this era, we're also not giving proper health care, proper education, and all that stuff. And this cultural sense of having a lot of children just carried over because that's what we did. That's what we actually have to do to survive, to, ensure that we were showing that we were useful and all that stuff in the slave industry era. And so then when we get into more modern times, that's when we're starting to get the whole image of the welfare mom. It's actually the mom who doesn't want to work and just having all these kids, and now it becomes problematic. And then you see the types of birth controls that are offered in certain types of communities. Then it progresses into now where we are offering different types of services and education that we're offering and who we're offering it to. When I talk to some of my white peers and colleagues and friends, they knew about freezing their eggs from when they're 18, 19. It was a conversation, it was a discussion, and then they were able to plan their fertility. They want to study abroad, and then they'll meet their partner, they'll date that partner for X amount of years, and then they'll have children, and they have their eggs frozen and it's ready for them. But yet when I talk to my friends and all this stuff and just figuring out what was shown to us and discussed with us, it's always about birth control, avoiding pregnancy, just focus on your career. And so then we get to this phase where the Black woman and her fertility has just been neglected for generations, just in different ways.
I think it's so powerful. We're talking a lot about the privilege of what you're saying of planning your fertility and the privilege of owning motherhood on your own terms for Black women. Can you maybe expand on that a little bit more in terms of what you're seeing?
Yes. So it's hard, right? Because we definitely want Black women to thrive in their careers, but it's something that I saw in my main PhD study, that these women were faithfully going to their gynecologist every year. They're the ones that schedule their annual exam around their birthday. They haven't missed it in years, but the conversation is not happening. And so then they're getting older and older, and they're not able to know what they should be considering. Also, understanding their full spectrum of options. There are some people who are okay being a single mother by choice. And had they known sooner, they probably would have explored it maybe a little bit earlier. Not everybody wants to have a partner in raising a child. So that's also different options. Or it allows that person to kind of have more serious conversations with their partner instead of pushing it off. They might put a pause in their career for a second. And I understand there's a lot of caveats to this. This country doesn't have paid leave or federal mandate for it. Different states differs, but at least having the tools and the information would actually help make it an equitable playing field in terms of how we plan for fertility.
Absolutely. And so there's this idea of being able to make the decision. What are some of the factors that you can't control? What are the biological or social factors that increase women's risk for infertility?
When I'm doing my fertility coaching, we'll talk more about it a little bit later. I'll have people say, well, I get my cycle every month, 28 days and all this other stuff. To your menstrual cycle, there's actually two different things going on. There's your uterus building the lining, and that's the flow that we will see when we think of a traditional cycle. But we're also interested in the ovaries as well, too. How is the health of the ovaries doing? Are they properly forming an egg that is supposed to be there to ovulate and help in conception? So for the uterus, thinking about that, you have fibroids, you have endometriosis, you could have different shape of the uterus. Sometimes people don't realize they don't necessarily have a uterus that would actually expand uniformly for a baby to actually grow and reach the end of a gestational cycle. And so that's when you'll find people who have something called recurrent miscarriage. So they can actually conceive, they can get pregnant. However, they're not able to actually get to the point where they can hold a live baby. And so also there is something called diminished ovarian insufficiency, where basically someone's egg quality actually diminishes a bit quicker over time than what we should normally see over the spectrum of their reproductive health life cycle. But typically after 35 years old, there is a big drop in terms of the quality and the number of eggs that are available. And then we think of some external factors too, as well. There's some people who might have had certain medications, maybe even had some cancer treatments that have rendered them infertile. I know there's some Black women with sickle cell disease who have done some experimental, which is great, the bone marrow transplants as well. But the bone marrow transplants can actually render you infertile as well too, because it just does a lot in terms of the immune system. And then this is a whole nother podcast episode, but thinking of male factor infertility. Often people think that, especially Black men, they're just having babies all over. You had that one uncle that had 10 kids, right, by a few different women. But male factor fertility is actually a huge issue. And of the 400 women from my study, I believe it was around 40% of them had some sort of male factor fertility issue. Yeah.
So how are women then finding out that they're infertile? How does it occur and how do they respond when they figure this out?
Yeah. So from the women in my study and the women that I talk to, it just doesn't happen. They're not conceiving. And sometimes because we're not necessarily always planning to get pregnant, they're just not putting certain things in place to not get pregnant, if that makes sense. They're just not using condoms or on birth control. They'll come to me like several years later and they're like, I'm just not getting pregnant. Like, it's just not happening. I was like, well, have you been trying? And then we kind of talk a little bit more. But for the most part, I have one group of women who just wait years and realize, hey, I realize all my friends are getting pregnant, or people in my circles. I've gone to a lot of baby showers, but none of it is for me. And then I have another group of women who just had these really, really, really invasive surgeries where they either lost a fallopian tube or their ovaries because of endometriosis or an ectopic pregnancy, which essentially a pregnancy is forming in the fallopian tubes when it should have went to the uterus. Or they just have these really large fibroids that have developed a lot of scar tissue. And thankfully, they had surgeons and GYN surgeons who provided that information for them. But I did have a subgroup who, this woman, she didn't have both of her ovaries and fallopian tubes, and she didn't understand why she wasn't getting pregnant because she was never educated.
What are the options when a woman comes to be aware that they're infertile?
Yeah, so this is also one of my favorite things to educate on. And I think part of it was doing a lot of my research in North Carolina. There's a huge religious component to it. And so a lot of people were very turned off about going to a fertility doctor because they thought it was just going to be IVF and embryos, and they're going to have a lot of ethical issues and concerns. That's what they felt like. So I'm actually developing a course, and so this is motivation to finish it, for pastors and clergy discussing the range of options of fertility. So some of it can be like super like non-invasive in the sense of some of these women are just not having sex at the right time of the month. They're not having intercourse when they're ovulating.
Right.
And so people are just like, well, we're only available on weekends. I was like, well, if you're ovulating Mondays and Wednesday, that's not going to work out for you. So part of my education is, okay, when is your menstrual cycle? We talk about, typically 2 weeks later, depending on the flow, but typically 2 weeks from the first day of your menstrual cycle, that's when you're most fertile and you're ovulating and stuff as well too. We could talk about even doing an ovulation tracker and understanding that. So giving you the most optimal window. Some of it is genetic counseling. Some people don't realize there are certain genes, especially if it's on the XY chromosomes or an extra chromosome. A lot of those can actually render people infertile even prior to trying to conceive. Some of it is just going to see a specialist. And what they do is different scans and procedures just to look at the shape of your uterus, looking at if there's anything impeding where an egg and a sperm could implant as well too. And then hormone testing. It's really non-invasive and not as expensive as most people think. on the third day of your menstrual cycle, usually that's when providers are going to have you check your estrogen and progesterone and luteinizing hormone and follicle stimulating hormone. And they sound a lot more scary than it really is, but those are all the hormones involved in you ovulating in your menstrual cycle being normal for you as well. And so then they look at all those numbers and they figure out a plan from there. And so if it sounds like somebody hasn't necessarily tried to have intercourse in that window, then that's what the doctor will suggest. Or then you get into treatments like intrauterine insemination. That's something where, the numbers are kind of looking like, yes, you might just need a little bit of boost and help on your hormones. And then also maybe your partner might not have like the strongest sperm count, but it's okay. And so in that procedure, they essentially take a sperm sample, wash it down so it's more like the strongest, toughest sperm, and then they might typically give the female partner some medications to really, push her ovulation, making sure she has good egg quality. And all they do is just mimic the timing of intercourse and like conception. And then they just insert the sperm sample into the uterus. And then a few days to a week or so later, then they do a blood test for pregnancy. Then you go into in vitro fertilization. And so that is where a person would be taking medications to really stimulate the follicles. Typically a month, you're going to have one dominant follicle that's going to help with conception without any medications. And so with the IVF medications, they want multiple dominant follicles. And so then right before you're actually about to ovulate, they go in with an ultrasound and a really long needle through your uterus, and then they pull out the mature eggs, and then they look at it under a microscope and all that stuff. This is where embryologist comes in and looks at the better quality eggs, and then they'll introduce a sperm sample as well. And then over a course of 5-6 days, they'll see how those embryos develop. Typically, not all of them will develop into an embryo. Then at the same time, the female partner is taking more medication to help with the lining of the uterus, because that's the second part of the menstrual cycle, and really getting that thick enough. And then they'll introduce the embryo. And then from there, about 7 to 10 days later, there'll be a blood test.
Black women have fewer options when it comes to finding other Black women who have donated eggs. Can you discuss what's going on there?
Oh, yeah, that's definitely a multifaceted issue and a future research dissertation if somebody wants to take that on, because a lot of work needs to be examined in that, who's being recruited. And so I think I've seen some ads and stuff like that about egg donation. Part of it is just because of like my algorithm of that research. But I've definitely, talked to some of my younger cousins and they're like, I have no idea what you're talking about. But yet on certain college campuses, a lot of these egg donor banks and stuff are actually setting up and educating certain people on that. And then, just education, even on the sperm donation side as well, too. Education on establishing parenthood. Some people feel like, oh, can they come after me for like child support or something? No, there's all these legal parameters that are in there that you can be educated on as well, too. And then something I recently learned is that certain donor banks actually get approached by a lot of diverse groups. It's the health status that prevents them. So when you approach, either egg donor or surrogate, which is a whole nother conversation, agency as well, too, they look at your health and then they look at least like 1 to 2 generations before you. So if like your mother or your father have had certain like heart disease or certain issues, whatever, that tends to disqualify you. And so most egg banks are pretty strict. So you need like a clean bill of health. And so when you think of the Black population and our access to care and how we're affected by preventable diseases, even the funnel just gets smaller and smaller.
Mm-hmm. As I'm listening to you, I'm thinking, will I be able to get time off work to do this? How much is this going to cost? And I'm in a position of privilege where I have flexibility in my job and I have good health insurance. How does that play into these decisions?
That's where planning this all out and talking it out and even choosing the right provider is going to help with the experience as well, too. So first, in terms of the finances, there's actually 19 states that cover some sort of fertility treatment. They all differ. So if you were to look right now, Massachusetts and Connecticut and like Delaware have some of the most comprehensive. So they'll cover the initial testing, like I said, all the scans and blood work, IUIs and IVF up to a certain point. Usually it's like up to 3 cycles. But in a place like Maryland, at the time when I did my research, they only covered 3 cycles of IVF. But that did not include like the medications that come with IVF. And so there's a lot of things that kind of come into play and a lot of barriers that are made at that point. So what if the doctor's like, well, IUI is going to help. So now you have to pay out of pocket for that. But if you need IVF, then it would have been covered a little bit more. And so part of my coaching is actually, I have an arm of it speaking to human resources and all the HR professionals to actually help them garner the types of insurance that would cover these treatments for their patients as well, too. And companies like Google or Amazon, they actually have benefits for freezing your eggs as well, too. And so you're right. You do have the privilege of, say, you needed to go do your scans and have your levels checked every couple days. But this is where someone would really have to advocate for themselves. And then talking to their employer, like, hey, this is a season. And the whole cycle, start to finish, is about 4 weeks. It's all around like your menstrual cycle. And if you're freezing your egg, the whole thing takes about 2 weeks as well from start to finish. So it's not, it can be long if you have to do multiple cycles, but it's a rather short situation. And then this is where I would educate somebody on choosing their fertility clinic. Being with somebody who is actually closer to either your work or neighborhood and has more flexible hours. A lot of them open at like 6, 7 o'clock in the morning to do the lab work and scans, especially when you're in the phase of stimulating your ovaries. You actually have to come in every couple of days just to make sure the medication is working. And sometimes the doses have to go up or down if based on the response that they're seeing.
When you're looking at the women that you have been able to recruit into your study, I know one of your studies found that they tended to be older.
Yes.
So can you comment on that?
So we're just coming in much later in life when we have these challenges. And part of it was, I did have a smaller group of, they could have been with their partners a long time, and they're the ones that waited 10 years or so to come in. Or I had a lot of people who did get partnered later on in life. So they were in their like 40s, just got married and tried on their own, and they're trying to figure out what's going on. Why is this not working? And so I didn't publish this information. It was just something I was very curious in the moment. I did a random sample of Caucasian women at the clinic, and they were several years younger than the Black women. And a lot of this, which kind of took me into my postdoctoral work and ultimately starting Fertility Goals, the coaching company, is like, we need this information. We need this right away. If you see someone getting married at 40, don't just say, oh, I hope you guys have a whole bunch of babies and all that like that. It's like, no. Like, if you're close to that person, right? Not just anybody can have these conversations. If you're connected with that person, you're like, hey, if this doesn't work out for you, if you want children, make sure right away you go see a specialist and you're not waiting over a year.
And I'm so glad you brought up your company, Fertility Goals, because again, you are a doctor, a researcher, you've done all of that type of work, and now you've taken on an extra role in terms of being an infertility coach with your company. Maybe you could talk broadly about what Fertility Goals is doing.
Yeah, so it's definitely an entrepreneurial venture that is based on my research 100%. So it is going to be kind of hard to separate them, but I need to make sure I separate them, conflict of interest and all that. But overall, so in my PhD work, I found a lot of these women were waiting long. They didn't have the information, they knew nothing. And like I said, they were going to their providers every single year. So why were these conversations being had? And so when I was in my postdoc, I did this paper that I'm hoping to publish very soon. I interviewed primary care providers and general OBGYN. Basically, I asked them, I was like, hey, do you ever talk about family planning? They said, yes. I asked them about, what birth control do they want and all this other stuff. I'm like, okay, But what about family planning in the sense of it's a holistic experience of when do you want to have children and what are your options? And many of them are like, oh, no, not really. And they'll talk about, well, and I'm also a family nurse practitioner, so I'm very well aware of the healthcare system. You get 15 minutes for this level visit, 30 minutes for that level visit. For an insurance company to pay you back for 45 minutes or more, I have to do like a ton of documentation saying it was worth the time as well. And so I understand them saying, I don't have time to talk about all this. And sometimes people don't even know what they want. And so from there, I'm really just trying to see like, okay, what is the intervention here? And so I just love card decks. I love playing the games, all the get to know you card decks. And so there's definitely been a rise in a lot of them for like relationships and friendships and families, or for people to get to know one another. And so I said, oh, what if all these different points could become a card deck? And then from there, the card deck actually was the foundation of the coaching company of, okay, after someone does the card deck, I could be there to help them. There's about 46 different prompts in the card deck, and I'll just talk about like one or two of them. One of them, especially affecting the Black community, is wanting to be genetically related to your child. At a certain point, a lot of the women's ovaries were not functioning properly, and they didn't have any eggs that could conceive a child. Their uterus was fine. They had no fibroids, but now they're being presented with donor egg and sperm, and they're having trouble there, trying to wrap their mind around that. So if somebody in their 20s can say, yes, I want to be related, or that's maybe not an issue for me, so I would explore adoption or donor egg and sperm. That's something that we talk about. But mainly the coaching company is there to educate all people, whether you're an individual, you're not even thinking about dating right now, you don't even care, you just want to live your life, or couples in the dating stage. Ideally, I could hit them in the premarital stage as well too, because not just for Black people and women, but for all couples that experience fertility challenges, they actually have a really high divorce rate as well too. And so it could be challenging because one person is willing to go into treatment, sell the house, and do fundraisers, and the other person's like, no, if it's not working, it's not working. Can we have these conversations ahead of time of like, okay, what would we do? Also, just going into different organizations, teaching clergy, like I said before, clergy, pastors as well, who are getting these people, because a lot of the women from my study did say, I went to my pastor and they just told me to pray about it and all that stuff. And I see the power of prayer. I get it. But God, I believe God also gives us the tools. We wouldn't tell somebody who has cancer to just pray about whether or not they should start their radiation or chemo. We would say, oh, okay, get that done. I'll support you and all this other stuff. We wouldn't tell somebody who has high blood pressure to pray about whether they should take the medication. We would say, like, why haven't you started that as well, too? So it's all modern medicine. And I know there's a lot of ethical things that intersect that makes this a little bit different. But overall, sometimes my work is to just educate people of their options.
So if someone comes to you, you start with the deck, then you start figuring things out. And what typically happens? Do you follow them through the whole infertility process, help them with the decisions?
Yeah. And so that's where, the client, individual, whoever the client is, could be a couple, they kind of figure out what they'll need help with. I could be very a la carte. We could just touch base. We do the card deck, we talk about it, and then you do your own thing. I've given you the options. I can talk about this one couple that I'm working with. They both have the sickle cell trait. And so for them to truly eliminate the gene and also not risk having a child with sickle cell disease, they have the power at this point to prevent it if they don't choose. Some people are okay risking it. So basically, it's really important for their child to be genetically related to them. It's important that their partner is on board with whatever the treatment is. And then they were willing to go into financial debt to have a child. And so what we discuss right now, they don't have positions that cover IVF. But what I did say is, hey, consider getting a new job. One of them is in a healthcare field where it's very flexible. Maybe go to the hospital that offers that benefit. Start talking about, different options of fertility providers. And so we actually went in, found a few in their area. And then I said, okay, you can call them and see who does maybe a free consultation, because some people will do free consultations just so you could talk to somebody what your options are in that area as well. And then you could come back to me because, again, healthcare, they don't always have the time to explain certain things. So I'm there for them at any point if they want to follow up with information, or if they find a provider of the list that we found together that they're super comfortable with, then I'm just cheering for them on the sidelines.
I know you work cross-culturally. You work with people of any race, ethnicity, sexual orientation. But I was wondering, what is unique about you being a Black woman doing this work?
Oh, yes. It's the way I communicate and the way I can talk to people. That's something that came up. People were talking to them like they're dumb. And these are like college and master's educated people. Just because somebody has a master's degree, like I don't go to a plumber and then expect to know all the things he's talking about and stuff. But I do want respect and break it down. Even the ways that I break down things now, I just really try to make sure that it's people can understand it because it's their body. And then I have a 3-year-old. I didn't use any fertility treatment to have him, but the ways that he has shaped my life, there are times where I just look at him and I'm like, I want this experience for other people. And yeah, overall, I feel like I'm just able to connect to various groups, but of course to Black people. I can say things like, girl, why did you wait that long? Like, we can have that laugh and we can, take down the anxiety and be ourselves. I've had clients who we talk in our bonnets, and so while they're in their bonnet, I'm like, it's okay. Be yourself. There's no airs about it. Part of me is just like, sometimes people see the different titles in my research, which I definitely work hard for, but I'm a girl from Bridgeport, Connecticut. Like I love chilling.
No, I think that's important because it builds the intimacy. So if you had to give advice to Black women today who are wanting to become pregnant and haven't checked for infertility or are having difficulty, what would you say to them right now?
Yeah, explore your options. And even if you've always had the desire for children, even explore that, right? Work with a therapist. Sometimes there are things that are just cultural, we may not always want. Some of them are like, I don't even know if I want to have kids. I'm like, that's okay. It's okay too. Overall, no matter how old you are, where you at in life, I would definitely recommend just getting the baseline testing, knowing your options, knowing what's available to you. In terms of egg freezing, you can explore that and you really want a partner. I would explore that today because I heard it one time and now I just repeat it all the time. It's never too early, but there is a point where it can be too late. You can be 22, 24, 25 right now, less than that. You never know what could happen. And the same way that we get car insurance and we never have to file a claim, that is also a reason why we can pay the storage fees as well too, and just put that a part of your budget. That was nurse practitioner and fertility coach, Dr. Morine Cebert. You can find out more about Dr. Cebert by visiting this episode's page on our website. You can also get more information about her coaching program, read her articles, or access her website and media handles by visiting that same page. And don't forget to check out her Fertility Goals Conversation card deck. This was developed by Dr. Cebert to help people define their path to parenthood. Thanks for listening to this episode of the Psychology of Black Womanhood podcast. We have some great guests already lined up for the upcoming episodes, so be sure to check out our topics by going to our website, www.psychologyofblackwomanhood.com.